Thank you. I am really, truly delighted and honored to be speaking with you today in Geneva. And I want to express my gratitude to the really new and exciting Center for Emerging Viral Diseases, which is just a wonderful institution which has just been begun here at the University of Geneva, and also express my gratitude to Professor Laurent Kaiser and to Professor Dan Bausch. So, I am not a scientist. I am a writer, and my business is language. I'm an educated humanist. I have no training in science or medicine. My degree is in literature, and my work is storytelling through the medium of language. Now, storytelling and language are extremely ancient human things. The modern human species dates back about roughly 100,000 years, and certainly modern language is at least as old as that. And the essence of humanity, really, what makes us human, is expressiveness. This is what we see in the archaeological record. We see humans using various different kinds of languages to express complicated ideas, complicated notions, complicated emotions. And in the medium of story, this is how humans pass important information from one generation to the next, through telling stories. So we not only tell stories, but we listen to stories. So that as I write about science, what I really am doing is I'm just being a writer, no more or less than that. I happen to have a deep interest in science, but I have an equally deep interest in human existence and in those things which make us human beings alive on this planet. I love telling stories about people, and science is a wonderful area to explore because we can explore nature, the wonders, the terrors, the horrors, and the beauties of nature. And at the same time, I can do the same thing. I can explore the wonders and terrors, horrors, and beauties of the human spirit, the human condition. So what I do as a writer, I don't normally work in the area of fiction, of writing novels. Instead, I write narrative nonfiction. So I write true stories that are researched meticulously through hundreds or thousands of hours of interviews with subjects of mine. And in fact, I'm now working on a new book about emerging viruses, and I've been interviewing some of my scientific friends here at the conference. I'm a traditionalist. I rarely use a tape recorder. I use a small notebook like this, and I write in pencil while I interview people. And I pay very close attention to what I'm hearing and seeing. And it's not just the words that they say to me, but it's also everything else about them. And then I go back and I interview again and again. People can sometimes say very unguarded things. They can sometimes, I shouldn't be telling you this because here I am, I'm interviewing you. But sometimes scientists can become like chimpanzees with Jane Goodall. And the chimpanzees sort of forgot who she was or what she was doing there. And then they say very unguarded things. And of course, I have my little notebook out. So, for example, the first time I ever met Dr. Peter Jarling at the United States Army Medical Research Institute of Infectious Diseases, Dr. Jarling is the discoverer of the Reston Ebola virus. So, very first interview, I was interviewing him, and I said to him, "Did you ever have a close call with Ebola virus?" And he said, "Oh, well, yes, of course. Everybody who works with Ebola sooner or later has a close call with Ebola." And then he proceeded to describe to me how during the Reston outbreak and the investigation, he inadvertently smelled or whiffed from a flask of cells that were extremely hot with Ebola virus. And then afterwards, when he realized that he'd had a major exposure to Ebola, he chose not to tell his commanding officer about it. He kept it a secret, and he just tested his blood every day to see whether he was going to break with Ebola. Now, he forgot, when he was telling me this story, he forgot that I had my little notebook out. And later, when this entire scene was described in the hot zone, Peter Jarling said, taking a whiff of Ebola virus was the second stupidest thing I ever did. The stupidest thing I ever did was to tell Richard Preston about it. So anyway, so beware. But don't worry, because I fact-check everything. I don't write anything as a journalist down unless I'm absolutely sure of my facts. And I don't normally make a habit of making people feel bad or look bad. So it was 22 years ago when I really became interested in emerging viruses. This is a very big story, and it's a continuing story. And in a way, it reminds me of the Peloponnesian War as described by Thucydides. You know, it's a war that's going on and on and on. And as a writer, I just happen to be privileged to be in a position to follow some of the protagonists and write about it. But it's a great story because it holds life or death consequences for every single human being on the planet, and also for future generations as well. So it has an enormous weight as a story. So I would like to tell you a story. So allow me to introduce you to Dr. Jean-François Ruppol. He was a Belgian physician. Some of you in the public health arena may know of this individual, but many will not have heard of him. He was a player in the original 1976 outbreak, the very first identified outbreak of Ebola virus in Yambuku in the Democratic Republic of Congo, which then was called Zaire. Here we have an image of him. He's 32 years old, and he's, as you can see, he's somewhat of a peripheral figure. He's not a very, apparently not a very important person in this scene. Jean-François Ruppol was a so-called bush doctor. He was a traveling doctor who traveled around Zaire, visiting hospitals, treating patients, and getting the hospitals into shape. His first language was Lingala, mixed with French. He also spoke Kikongo fluently. And he worked also as an epidemiologist and a public health doctor, as well as just a regular bush doctor physician. I'm describing his work in my new book on emerging viruses, which is going to be published probably next year. And so that's what he is. He's just another public health doctor. Now, in 1976, October, Dr. Ruppol was the director of the Fonds Médical Tropical, or FOMETRO, which is a medical relief organization headquartered in downtown Kinshasa. And one day in early October, he got a telephone call from a reverend sister of the Catholic Church. And she said that there was a strange malady that had been killing nuns upriver in Bumba Zone at a place called the Yambuku Catholic Mission, where there was a hospital. A Zairian physician, Dr. Jean-Jacques Muyembe, had gone there, suspected yellow fever, but there was no laboratory confirmation of yellow fever, so the thing was still unknown. And so Dr. Ruppol, accompanied by one Dr. Gilbert Raffier, who was a French military doctor, and another doctor by the name of Dr. Krubois from the Zaire Ministry of Health, traveled to Bumba Zone. And there, Dr. Ruppol and the others saw his first case of Ebola virus. And it was a couple, school teachers, a husband and wife, both of whose children had died of this then unknown malady. They had caught it from their children, and they were both dying in a hospital room, and the man was sitting in a chair, upright, on a chaise longue, with one leg bent on the ground and leaning on the elbow of the chair, and his hand formed into a fist, and his eyes were two carnelian stones fixed on his wife. And she lay curled up in a mattress, dying. And the room was scattered with feces, vomitus, blood, urine. It was a dreadful scene. Now, the question was, how could these three doctors stop this outbreak when they had no idea what it was? I like to think of public health doctors as something like jujitsu masters. They're like unarmed warriors in some of the greatest medical wars in human history. And in terms of public health, of course, there are more lives at stake than there would be in a great world war, potentially. Millions and millions of people can lose their lives to an infectious disease very quickly. So as a jiu-jitsu master, the public health doctor is observing. Dr. Ruppol and his colleagues were observing these two patients, and they were trying to determine everything they could possibly learn about this virus. The jiu-jitsu master looks for the fulcrum of imbalance, the point of weakness, the weakness of the infectious disease. Already, Dr. Ruppol suspected a hemorrhagic fever virus of some kind. And if you think about it from the point of view of a virus being a monster, if you can find the weakness of the monster, you can find a way to throw it down, even if you're unarmed with the tools of modern medicine. Now, to think about it from the point of view of a virus, if you can think of a virus as having a point of view, a virus is not an individual. A virus is actually a swarm of individuals. It's a huge number of individuals. And the swarm occupies a human body. But the point of weakness of a virus is when the swarm has to migrate. It's the act of migration to a new host when that large number of particles is reduced to a very small number of explorers, just a few particles that escape from the original human host and are attempting, so to speak, to find a new host. And it's that moment of weakness. If a public health doctor can determine the mode of transmission, then there can be a possibility of stopping it. So Dr. Ruppol and his colleagues concluded that whatever this thing was, it did not travel in the air. It traveled only in direct contact with blood and liquid humors of the body. So shortly afterwards, Ruppol went to the marketplace in Bamba, where they had put up signs, come to the marketplace and learn about the disease, the malady. So about 500 people in town showed up, and the crowd was nervous, scared, subdued, frightened. It was a crowd where it was just seething with various kinds of emotions. And Ruppol borrowed a table from a vegetable seller in the market, and he stood up on the table and he began to speak in Lingala to the crowd. And here's what he said. He said, first of all, how are you going to stop the virus? He didn't place himself as the doctor as being able to do it. He had to ask the people this rhetorical question, how will you stop the virus? And he said, here's how you can stop this thing. First of all, know the symptoms. And then he described the symptoms as he had just witnessed them. Secondly, he said, avoid close contact with people who have these symptoms. This malady travels from person to person through the liquid humors of the body. So he said, you can gaze on the body of a dead person, pas problème, but do not touch the body and bury the body quickly. And finally, the third thing he said was, here we have some views of what it really looked like. This is the hospital. He said, follow the ancient smallpox rule, l'ancienne règle de la variole. This is, for centuries in the Congo Basin, when smallpox came to a village, the villagers would take all the infected people, many of whom were children, and put them in a hut. They would build a special hut outside the village. This was an isolation hut. And the victims of smallpox would be placed in the hut with an adequate supply of oral hydration, water, and food, and left there. And then after a certain period of time, some people would emerge from the hut. Those who did not emerge from the hut were dead inside the hut, and the hut would then be burned down with the bodies inside it. Many of the bodies were the bodies of children who had expired. So the ancient rule of smallpox was a harsh rule, but smallpox was harsher. And the interesting thing is that today, in the most recent outbreak of Ebola virus, we had no vaccine, we had no drug that would work against Ebola. What we had, in effect, was the Ebola isolation units, which were a modern, updated version of the ancient smallpox rule. We had people were placed in isolation. Initially, they were given oral hydration and food. Later on, it was determined that IV hydration would probably be better, more effective at saving lives, but initially, it was only oral hydration. And then, of course, you either walked out of an Ebola treatment center or you were brought out dead. So this illustrates, in a way, not necessarily the failure of the modern medical system, but simply our helplessness in the face of an emerging viral disease for which we have no good treatments. We were, in effect, we were placed partway back into medieval times by Ebola virus. So Dr. Ruppol went back to Yambuku for a second visit. This time he was the fixer and the guide for an international team of epidemiologists who were going to investigate what was happening at Yambuku and try to interrupt the infection. When they got there, they found out that it appeared that the people had already begun instituting the ancient smallpox rule. And they documented at least 2 villages where people were placed in isolation huts who had Ebola virus. And they were also, people were blocking the roads to prevent travel between the villages. And they were beginning to also recognize the disease, not touch people who had it. For a temporary period of time, the burial customs changed. And the people of the Congo Basin really adapted very quickly to the new and changing situation with Ebola virus. Now, the night that Ruppol arrived with the team, he was, after all, a bush doctor. And he was awakened at 4 o'clock in the morning by a nun, Sister Genevieve, knocking on his door. And she said it was an emergency. A patient had just arrived at the hospital and was at death's door, and could he look at the patient? So he goes outdoors, it's pitch dark, and for light, they had a pressurized gas lantern and a flashlight, no electricity. And he found a woman lying in the darkness in the grass on a litter. Her relatives had brought her there. She was in childbirth, and she was desperately ill. Examination with the flashlight showed that she had the classical red, bright red eyes of Ebola, which then, of course, had no name. She was shaking with a very high fever, and she was close to death. And not only that, she was in childbirth. When Dr. Ruppol inspected her, he found evidence of hemorrhage from the birth canal. Now, already it was known or believed that a pregnant woman had virtually 100% chance of death if she were infected with this agent, and that the baby, the fetus, would always be lost, be stillborn, or would die shortly after birth. So the woman appeared to have no chance. However, Dr. Ruppol decided to take the chance anyway to try to save her. And he had a method for dealing with a woman. The woman was stuck. The child was in breech birth. And in those days, he practiced a very simple, primitive procedure called the Zarate procedure to remove a baby in lieu of a C-section, a cesarean section. Dr. Ruppol did not practice cesarean sections in the Congo Basin because a woman who'd had a cesarean would be shunned by her village as being mutilated. So the Zarate procedure was a somewhat less invasive alternative to this. So, but he had to do the operation on a table. They found a table somewhere. They put it outdoors on a porch because the entire hospital, especially the OR and the maternity room, were utterly contaminated with blood, infected blood. So they got her on the table, and there was, the nun was Sister Genoveva, and then there was a nurse, a man by the name of Sukato Manzobe. And the two of them got the woman up on the table. Dr. Rupol prepped for surgery. He was aware of the biohazard, so he put on a surgical gown, rubber gloves, a mask, head covering. And then by the light of the lamp and the flashlight, he proceeded to do the surgery. Now, there was no anesthetic. So he had the nun and the nurse hold the woman's arms and legs still to keep her from thrashing. And then he took a scalpel and he cut the pelvis, right at the front of the pelvis. The pelvic bones join in front and are attached by a very tough piece of cartilage. The bones are not actually joined entirely. And you can find this spot. It's called the symphysis pubis. It's right above the pubic area. It's a hard, bony spot right above the pubic area. It's right in that spot where he dug the scalpel in, and then he made a vertical incision of about 1 centimeter, just enough to help the hips spring apart. And then he got his hand inside behind the child, and he brought the baby out, along with a tremendous effusion of amniotic fluid, a certain amount of blood from the incision. There may have been bleeding from the birth canal as well. And then he held the baby up, and by the light of the lamp, he had not saved the baby. The baby wasn't breathing. And so, without thinking, he tore off his mask, and he placed his face on the baby's face, and he began to very gently inflate the lungs. You have to do this very slowly, or you can burst the child's lungs. And while he was doing this, the nun and the nurse drew back in shock, and they witnessed a change in Dr. Rupol at that moment. About halfway through trying to save this baby's life, the man seemed to go into shock. He had forgotten himself, and he suddenly realized what he was doing. But at this point, he had had a total exposure to the virus, and there was nothing he could do except to continue to try to save the child. So he got the lungs inflated, and then he pulled the baby away from his face, and his face was absolutely covered with mucus juice, just a mucus, and blood. It was an absolute mess. He had it in his eyes and his nose, his mouth, and everywhere. And one of the two witnesses, it was probably the nun, I'm not sure, said to him, "Doctor, do you realize what you have done?" And he answered, "I know now. Je sais maintenant." So Dr. Rupol had acted on instinct. He had done this procedure more than 1,000 times, and he just went through it on instinct. It was simply, he did what a doctor must do to save a life. It was his training had taken over, and it had overwhelmed his conscious mind, his ability to make decisions. And what he had done, actually, was he exchanged his life for another life. And it was a week later that the radio in Kinshasa reported his death. He had died so swiftly, he had been so terribly exposed that he had not been able to return to Kinshasa to get help. He had died in Bamba. Now that brings us to the Kenema Government Hospital. So part of my new book is about the events that took place at the Kenema Government Hospital in Sierra Leone, which was an epicenter of the Ebola virus. It was a very, very difficult situation, but once again, we found medical workers and physicians who were exchanging lives for lives. In effect, they were continuing to work in extremely contaminated situations where they had little hope of escaping infection by the virus, but they continued to work anyway because they were medical people, and that's all they could do, was to do the work. We lost Dr. Humer S. Khan, who was the head of the Lassa viral hemorrhagic fevers program. He was a great friend of Dr. Dan Bausch. We lost the head nurse, Auntie Mbalu Fani, who was known all over Kenema. And I'm just going to show you the faces of a few other people who were lost. This is from a little memorial wall at the Kenema Hospital. So this one I like particularly. Nobody seemed to remember who he was. He was just Mohamed Blango. He came into the hospital as a volunteer. I don't know where he came from. Nobody could really remember him. They couldn't tell anything about him except that he had died in connection with his work at the Kenema Hospital. And on the day that Dr. Humar Khan, began to suspect that he was infected with Ebola himself, he went into the office of the program administrator, a young woman named Simbiri Jallo, and he sat down in the chair next to her desk. And he said that he was hurting, he didn't feel well, and she started to cry. She suspected that he was already infected with Ebola. And here were his words to him. Don't cry, Simbiri. You don't cry. When something is really bad, you just do what you can do. This world is full of mystery. In this world, when you are strong and healthy, you do your part. And if you fade away, the next person will do their part. Who else will care for these people? Now, who else will remember people like Mohamed Blango, except for us writers? My job is not to perform science or to practice medicine. I'm completely incompetent in that. But what I can do is I can ask questions and I can remember. And I can remember this man who otherwise would be absolutely forgotten, even forgotten to his colleagues in Kenema. So at any rate, back to Jean-Francois Ruppol. The radio got it wrong. The media had made a mistake. He was fine. He arrived home in Kinshasa. He let himself into the house. He embraced his two young children. And then he encountered his wife, Josiane. He was sitting in the Grand Salon, in the living room, in the chair. And he stood up to kiss her, and she said, "No kiss." She felt that maybe alcohol could sterilize his mouth. And so she said, "Jean-Francois, have a whiskey." And she went to the liquor cabinet and she brought out a bottle of whiskey. And then she said, "No, have 2 whiskeys, have 3 whiskeys. Finish the bottle, but outdoors, not inside the house." So he went outdoors to finish the bottle of whiskey, which he pretty much did. And then somebody lit a fire in the backyard. And later, Josiane came out with his valise. And she opened it over the fire and poured everything in the valise, his trousers, his underwear, his socks, his toothbrush, everything went onto the fire. And then the valise went onto the fire, and she dusted her hands together. And she said, "Before you come into the house, be sure to take off your clothes and shoes and burn them too." So this is just another day in the life of a public health doctor. Jean-Francois Ruppol is alive and well today. He has lots of things to tell about the outbreak. Now, the story that I just told is effectively about what Ruppol did, which was an act of professional love, which is what public health doctors do. They don't do this for anything. They don't do it for fame. They don't do it for money. They do it because this is their job. And in telling the story about Ruppol, as a writer, it offers me not only the opportunity to tell a very interesting story about an interesting human being, but it also, one is enabled to describe a good deal of the science of epidemiology in a way that any reader can kind of understand. So you can attach the science to narrative in a way that really shows that the work of public health doctors really extends into the realm of every possible human emotion. And every aspect of human history can be looked at through the medium of public health and the management of a gigantic, difficult disease. I'm going to talk just very briefly about smallpox. Smallpox virus, of course, was declared eradicated in 1979 by the World Health Organization. And we've just lost one of the great figures, Dr. D.A. Henderson, who was the head of the smallpox eradication unit at the WHO. Smallpox was at one time, an emerging virus itself. It is thought that smallpox entered the human species about 7,000 years ago, when the human population got dense enough in the agricultural river valleys of the Middle East, where in order to sustain itself in a human population, variola, smallpox, needs to have about 200,000 people packed into an area in which all those 200,000 people are within about a 14-day traveling time from one another. And those conditions did not pertain in human history until about 7,000 years ago in the river valleys, at which point the human species became very vulnerable to a new emerging virus, smallpox. Smallpox is truly a monster. Hemorrhagic smallpox is particularly gruesome. But there is this question as to whether or not smallpox was truly eradicated. And we have now found out from a series of defectors from the former Soviet bioweapons program, biopreparat, that smallpox was developed as a biological weapon by the old Soviet Union. And it was developed specifically for use as a so-called strategic weapon of mass destruction. The difference between a tactical weapon and a strategic weapon is the difference between the nuclear bomb and any ordinary bomb. An ordinary bomb targets military targets. A strategic weapon targets civilian populations. So the evidence is that the former Soviet Union developed smallpox for use on civilian populations as a biological version of a thermonuclear bomb. Now, when the Soviet Union fell apart, a number of the scientists who were working for biopreparat just sort of dropped off the face of the earth, and they couldn't be accounted for by either Soviet intelligence or by US intelligence. Where they went, no one knows. Could they have taken a very small quantity of freeze-dried smallpox with them? Nobody knows. So nobody actually knows what the status of smallpox on the planet is today, whether anybody has it other than the official stocks, or what they might perhaps want to do with it. It turns out that pox viruses are among the simplest viruses to engineer. It's very, very simple. It's almost high school level molecular biology to put a gene into a pox virus. So we just don't know. We don't know what the future holds, or whether even, in fact, smallpox could become a re-emergent virus as a GMO smallpox. But I think about nature rather than weapons. And I think that the measles virus can give us something of an example of what we might think about when we think about emerging monsters of the future. Now, the difference between a virus like measles and a virus like Ebola is profound. Measles is a member of the morbillivirus family, and this particular kind of virus can exist in a perfectly dried form. The virus can attach itself to tiny dust particles, or it can actually form dried crystals, and it can remain completely viable. And this is how morbilliviruses like measles can travel from one host to another. Remember, a virus is a swarm. So the measles virus, it inhabits somebody, it makes them sick, but then it needs to migrate. Well, this type of virus has wings, and it can fly. And with Ebola virus, the principal risk behavior is to touch somebody who is infected with Ebola, to caress the body of a dead person, to get direct contact with body fluids. That's a risk behavior when you're dealing with Ebola virus. The risk behavior for a virus like measles is simply breathing. If you're breathing, then that's a risk behavior. Now, there was a time when measles was, in fact, an emerging virus. Measles has not been in the human species for very long. It appears to have emerged at about 800 years ago. So at about the time of the building of Beauvais Cathedral was about the time that measles virus emerged in the human species. And it evolved from the Rinderpest virus, which is a virus of cattle. Rinderpest is a morbillivirus that's very closely related to measles. Here's what the viral particle looks like. It's a pleomorphic particle. That means to say it has a blobby shape. It has sort of a messy-looking shape. But in cattle, it has a 100% mortality rate in unvaccinated animals. It is a really dangerous virus. And measles virus itself is an exceptionally lethal virus in non-immune populations. So when measles virus infected indigenous populations in South America, populations that had never before been exposed to measles, there's a very, very high mortality rate. So measles-like viruses, morbilliviruses, are particularly dangerous as candidates for emerging viruses. We could see a morbillivirus. Now, I want to give you an example. A Nipah virus, an emerger, is a morbillivirus. I'm going to tell you a little story. So this is a story of an outbreak of measles. It took place in July 1991 at the Metrodome. The Metrodome in Minneapolis is a sports stadium that has a roof that is inflated. And inside, it's absolutely vast. They play football, that's American football, and baseball there. And the roof is held up by air pressure. The air circulation in the building is excellent, and the air is changed. I think the air circulation is 7,000 cubic meters of air per second. So this is a building where the air is very fresh, very clean, and being constantly recirculated. Now, on July 20th, there was the opening ceremonies of the Special Olympics, which were held in this stadium. And all the competitors came in, and there was a 12-year-old boy, a competitor from Argentina, where it turned out later that there was an unidentified outbreak of measles going on. And this boy sat, here we have Prince playing. He played at the opening ceremony, and this is a still from a video, but if you watch the video, you can see the smoke. You can see the smoke drifting very rapidly from right to left like this. It's just blowing along. And the smoke is heading back toward the outer parts of the grandstand. In any event, here we have the boy sat right here in a privileged position right behind home plate. For those of you who aren't familiar with baseball, home plate is right here. The pitcher throws the ball, and then anybody who's sitting right here can watch those pitches as they come right across the plate. So this is the best place to sit. The kid had a very privileged position. Now, he also had a dry cough, and he had conjunctivitis, but he had no skin rash. His family thought he had a common cold. What he actually had was he had a raw spot on the back of his throat that was about the size of a postage stamp. And it was emitting particles of measles virus, probably in rather large numbers, but these were very, very small particles that dried out virtually instantly when they hit the air. Now, here we have a slightly different view of the layout. We have here, this is home plate. The kid was sitting right there. Here's where he came in. And there were two cases. People sitting right up here at the very top. several hundred feet away from where the kid was breathing. And in the investigation later, it was found out that, that virus particles from that little postage stamp sized bit of that boy's throat had evidently floated all the way, were carried on air that was probably coming in here, and then ended up right here where there was an intake vent that was pulling air through to recirculate the air to the outside. And so a few of those particles passed into the respiratory tracts of these two individuals who then broke with measles. The measles virus, morbilliviruses in general, are highly infective in very, very small doses. Now, there were, as a result of this one individual with measles, there were a total of 24 additional cases of measles connected to this one case. And there were 3 generations of infection. So people kept passing the measles. And this was in a well-immunized population, where most people had been immunized relatively effectively for measles. So what do we conclude from this? Well, I think we can conclude that, that the viruses have a lot of advantages going for them. And you can just see, imagine a morbillivirus with a mortality rate of anywhere from 10 to 25%, and imagine it spreading this easily in an enclosed airspace. Imagine how quickly it would go around the planet, and if there was no vaccine for it, it would be a disaster of just unimaginable proportions. But we do have assets that viruses don't have, that I think it's important to think of and be reminded of. First of all, unlike a virus, we have self-awareness. We can analyze our action. We also have the ability to work in teams, and we have a strong capacity for altruism, as we have just seen in the lives of physicians and medical workers who sacrificed their lives for the greater good, or who simply did their jobs without thinking too much about what that meant for them personally. But it was just a job. They had to do it. Somebody had to take care of these people who would take care of them. And we have another capacity that viruses don't have. We have the capacity to love and to express our love for one another through acts of sacrifice. The public health doctors, the people who work in the field of protecting all of us from emerging infectious diseases and all infectious diseases, effectively are motivated by what I would call professional love. And I think I would like to close by asking all of you to think a little bit about the work that the researchers, the public health doctors, the scientists who are working on vaccines and pharmaceutical cures for these emerging diseases. Think a little bit about their acts of professional love. And I'd like to ask you for a round of applause for the people who work in public health, including my friends and colleagues in the Emerging Viral Diseases unit of the University of Geneva. We are all grateful for them. They are, in fact, heroes who operate often under the radar, who are very rarely noticed for the incredibly important work they do in improving and protecting all of our lives and the lives of everybody to come. So I'd like to offer applause to you.